Hypersensitivity. First, let me define what is hypersensitivity. Hypersensitivity is defined as a heightened state of immune responsiveness. Typically, it is an exaggerated response to a harmless antigen that results in injury to the tissue, disease, or even death. Hypersensitivity reactions are based on four different categories. Type 1 hypersensitivity. The distinguishing feature of type 1 hypersensitivity is the short time lag, usually seconds to minutes, between exposure to antigen and the onset of clinical symptoms. The key reactant present in type 1 or immediate sensitivity reactions is IgE. Antigens that trigger formation of IgE are called atopic antigens or allergens. Atopy refers to an inherited tendency to respond to naturally occurring inhaled or ingested allergens with continued production of IgE. Typically, patients who exhibit allergic or immediate hypersensitivity reactions produce a large amount of IgE in response to a small concentration of antigen. In this table, it shows the mediators of immediate hypersensitivity. Clinical manifestations of immediate hypersensitivity. Type 1 hypersensitivity is a widespread health problem, as it is estimated that up to 25% of the population suffers from some sort of allergy. The clinical manifestations caused by release of both performed and newly synthesized mediators from mast cells and basophils vary from localized skin reaction to a systemic response known as anaphylaxis. Symptoms depend on such variables as route of exposure, dosage, and frequency of exposure. If an allergen is inhaled, it is most likely to cause respiratory symptoms such as asthma or rhinitis. Ingestion of an allergen may result in gastrointestinal symptoms, and injection into the bloodstream can trigger a systemic response. As for the treatment of immediate hypersensitivity, avoidance of known allergens is the first line of defense. This includes environmental interventions such as encasing mattresses and pillows in allergen-proof covers and not allowing pets inside the house. Another approach of treatment involves immunotherapy or hyposensitization. Testing for immediate hypersensitivity. In vivo skin test, it involved direct skin testing. Cutaneous and intradermal tests are two skin tests most often used. In vitro test, total IgE, it involves measurement of either total IgE or antigen-specific IgE. Antigen-specific IgE testing. It is the original commercial testing method for determining specific IgE was known as the radioallergosorbent or the RAST. Microarray testing. The newest generation of allergy testing involves the use of microarrays. Let us proceed to the type 2 hypersensitivity. The reactants responsible for type 2 hypersensitivity or cytotoxic hypersensitivity are IgG and IgM. They are triggered by antigens found on cell surfaces. Macrophages, neutrophils, and eosinophils have Fc receptors that bind to Fc region of antibody on target cells, thus enhancing phagocytosis. Natural killer or NK cells have also Fc receptors. If this link to cellular antigens, cytotoxicity results. If the complement cascade is activated, complement can trigger cellular destruction in two ways. One, by coating cells with C3b, thus facilitating phagocytosis through interaction with specific receptors on phagocytotic cells, or two, by complement-generated lysis if the cascade goes to completion. Hence, complement plays a central role in the cellular damage that typifies type 2 reaction. Hemolytic disease of the newborn. Hemolytic disease of the newborn, or HDN, appears in infants whose mothers have been exposed to blood group antigens on the baby's cells that differ from their own. Severe HDN is called erythroblastosis fetalis. The most common antigen involved in severe reactions is the D antigen, member of the Rh blood group. HDN due to ABO incompatibility is actually more common, but the disease is milder because the majority of antibodies formed are IgM, which cannot cross the placenta. To prevent the consequences of HDN, all women should be screened at the onset of pregnancy. If they are Rh negative, they should be tested for the presence of anti-D antibodies on a monthly basis. Autoimmune hemolytic anemia. Autoimmune hemolytic anemia is an example of a type 2 hypersensitivity reaction directed against self-antigens because individuals with this disease form antibodies to their own red blood cells. Symptoms may include malaise, lightheadedness, weakness, and possibly mild jaundice. Such antibodies can be categorized into two groups: warm reactive antibodies which react at 37 degrees Celsius and cold reactive antibodies which react only below 30 degrees Celsius. Warm autoimmune hemolytic anemia, accounting for more than 70% of autoimmune anemias, is characterized by formation of IgG antibody which reacts most strongly at 37 degrees Celsius. Some of these antibodies may be primary with no other disease association, or they may be secondary to other disease process. While cold agglutinins, a less frequent cause of immune hemolytic anemias, typically are found in persons in their 50s and 60s. These are thought to be triggered by antigens on microorganisms because antibodies have been known to occur following mycoplasma, pneumonia, and infectious mononucleosis. Testing for type 2 hypersensitivity. Direct antiglobulin testing, or DAT, is performed to detect transfusion reactions, hemolytic anemia of the newborn, and autoimmune hemolytic anemia. And the indirect Combs test is used for the cross-matching of blood to prevent a transfusion reaction. It is used either to determine the presence of a particular antibody in a patient or to type patient red blood cells for specific blood group antigens. Let us now proceed to the type 3 hypersensitivity. Type 3 hypersensitivity reactions are similar to the type 2 reactions in that IgG or IgM is involved and destruction is complement-mediated. However, in the case of type 3 diseases, the antigen is soluble. When soluble antigen combines with antibody, complexes are formed that precipitate out of the serum. Arthus reaction. The classical example of a localized type 3 reaction is the Arthus reaction, demonstrated by Maurice Arthus in 1903. This reaction, characterized by erythema and edema, peaks within 3 to 8 hours and is followed by a hemorrhagic necrotic lesion that may ulcerate. The inflammatory response is caused by antigen-antibody combination and subsequent formation of immune complexes that deposit in small dermal blood vessels. Complement is fixed, attracting neutrophils and causing aggregation of platelets. Serum sickness. Serum sickness is a generalized type 3 reaction that is seen in humans, although not as frequently as it used to be. Serum sickness results from passive immunization with animal serum, usually horse or bovine, used to treat such infections as diphtheria, tetanus, and gangrene. Vaccines and bee stings may also trigger this type of infection. Generalized symptoms appear in 7 to 21 days after injection of the animal serum and include headache, fever, nausea, vomiting, joint pains, rashes, and the recovery takes between 7 and 30 days. In this disease, the sensitizing and shocking dose of the antigen are one of the same because antibodies develop while antigen is still present. Autoimmune diseases. Type 3 hypersensitivity reactions can be triggered by either autologous or heterologous antigens. Several of the autoimmune diseases fall in this category. Systemic lupus erythematosus or SLE and rheumatoid arthritis are two such examples. In SLE, antibodies are directed against constituents such as DNA and nucleohistones, which are found in most cells of the body. While in rheumatoid arthritis, an antibody called rheumatoid factor is directed against IgG. Immune complex deposition occurs in the membranes of inflamed joints. Testing for type 3 hypersensitivity. In specific diseases such as SLE and rheumatoid arthritis, the presence of antibody can be detected by agglutination reactions using antigen-coated carrier particles, including red blood cells or latex particles, or enzyme immunoassays. Fluorescent staining of tissue sections has also been used to determine deposition of immune complexes in the tissues. A more general method of determining immune complex diseases is by measuring complement levels. Decreased levels of individual components or decreased sectioning of the pathway may be indicative of antigen-antibody combination. Type 4 hypersensitivity. Type 4 or delayed hypersensitivity was first described in 1890 by Robert Koch. Type 4 hypersensitivity differs from the other three types of hypersensitivity in that synthesized T cells, usually a subpopulation of Th1 cells, played a major role in its manifestations. There is an initial sensitization phase of 1 to 2 weeks that takes place after the first contact with antigen. Then, upon subsequent exposure to the antigen, symptoms typically take several hours to develop and reach a peak 48 to 72 hours after exposure to antigen. Contact dermatitis. Contact dermatitis is a form of delayed hypersensitivity that accounts for a significant number of all occupationally acquired illnesses. Reactions are usually due to the low molecular weight compounds that touch the skin. The most common causes include poison ivy, poison oak, and poison sumac, all of which give off urushiol in the plant sap and on the leaves. Sensitivity pneumonitis. This is an allergic disease of the lung parenchyma characterized by inflammation of the alveoli and interstitial spaces. It is caused by chronic inhalation of a wide variety of antigens and is most often seen in men between the ages of 30 and 50s. Tuberculin-type hypersensitivity. Testing for exposure to tuberculosis is a classical example of a delayed hypersensitivity reaction. This is based on the principle that soluble antigens from Mycobacterium tuberculosis induce a reaction in people who have or have had tuberculosis. When challenged with antigen intradermally, previously synthesized individuals develop an area of erythema and induration of the injection site. Testing for delayed hypersensitivity. The patch test is considered the gold standard in testing for contact dermatitis. This must be done when the patient is free of symptoms or when he or she at least has a clear test site. Another type of skin test for delayed hypersensitivity, the Mantoux method. It is performed in much the same manner as testing for the presence of IgE. Typically, 0.1 ml of the antigen is injected intradermally using a syringe and a fine needle. That's all for my report about hypersensitivity. The picture here depicts the summary of the hypersensitivity from type 1, type 2, type 3, and type 4.